So you're already sharing the screen, right?
Yes, so yep, we can start. All right, good evening, everyone. Thank you for channeling into NSSM Facebook and presenting to you. We're having now Every Breath You Take Series 2, where we're going to talk about biomarker and screening. Thank you for spending your evening with us. Today with us here, we have Dr. To, the clinical oncologist. We have Prof. Pathma here, and then we also have Dr. Murali with us today. So yeah, over to you, Dr. Murali.
Okay, thank you very much, Kenneth. Good evening, ladies and gentlemen. Thank you very much for coming into the second edition. So as the MCO seems to have wound down a little bit, we found that a lot of people don't like Saturdays anymore. Saturday is now the time to go out and have long brunches, long walks, go to Bukit Tinggi. So we decided to try switching the time a little bit to more like an evening teh tarik session. So I hope you all have your teh tarik glasses in front of you, your coffees, whatever it is that is your poison, and can give us about 30-40 minutes of your time as we go through this very interesting topic, which really we hope is of benefit to almost everyone in Malaysia, because cancer, especially lung cancer, seems to be a growing concern. Together with us today, as Kenneth already mentioned, we have Professor Dr. Padmanabhan and Dr. To Laiman, both very eminent oncologists and pathologists in their profession in Malaysia. In fact, I was just telling Prof how I've been actually his student as well many years ago. So really, there is very little in this chat room that is not encompassing perhaps the entire breadth and width of the knowledge in terms of today's session, which is on biomarkers and screening. So just kind of to refresh again, we would like to thank, of course, our partners, Roche, for kind of coming in to support us in this initiative. And of course, our colleagues in ARMS, Lung Cancer Network Malaysia, who we've kind of taken on this task together to educate a little bit better Malaysians in this field. So in our last session, which you can find on both our Facebooks actually, on the Lung Cancer Network Malaysia Facebook, LCNM, or on the National Cancer Society of Malaysia Facebook, we had Dr. To and Dr. Anand speak to us a little bit about signs and symptoms of lung cancer. And today we're going into another very interesting area, which is in terms of biomarkers and screening. And biomarkers and screening are very, very kind of an integral part of lung cancer, and especially a lot of new work has been done in this area. And together with us today to share it is our two eminent consultants, Dr. To and Professor Dr. Padmanabhan. Without kind of further ado, I think we're just going to swing just as a refresher slide in case anyone has forgotten and about kind of the information that we started sharing in the last session about lung cancer. I think we're going to have Kenneth put up that slide, and Dr. To, I think, will very kindly take us through some of the quick kind of issues pertaining to lung cancer that makes it of such concern today. Right, so maybe Dr. To, could you kind of just wrap up for us in like 1 minute, like why should we really care about this?
Yeah, thanks, Dr. Murali. Good evening to everyone. Thank you for tuning in. So I think as Dr. Murali hit the nail on the head, lung cancer is a significant burden in society. It is the most common cancer worldwide, and the incidence doesn't seem to be coming down. We know that lung cancer can be quite deadly, as the statistics show that it kills more people combined than breast, colon, and prostate cancer. So that's a significant, very significant statistic there. But the good news is, and that leads into what we are going to speak about today, that as our knowledge of the cancers have become more in-depth, So we are looking at the molecular markers on these cancer cells. We're understanding the genetic types of lung cancer. We are able to develop much better drugs that will target these defects in the genes.
Right, and actually, really, to kind of the focus of today that we keeping on coming back to is that we'll keep on coming back to is actually biomarkers. If you know, I always use a food analogy. I think Malaysians will only understand. I'm being horrible about this, but we all understand when we kind of give it a food kind of twist, which is really bad as well. But I'm going to give a nasi lemak analogy. And usually we all thought that all lung cancers were just nasi lemak. And now we're finding out that there's nasi lemak with ikan masin, there's nasi lemak with kangkong, there's nasi lemak with fried chicken, nasi lemak with, I don't know, any other variation that you can think of. Telur separuh masak, telur mata kerbau. So there's always these different versions of nasi lemak. So similarly, rather than thinking of lung cancer as really a homogeneous kind of disease, we're actually finding out there's so many different types or subtypes of lung cancer that we're looking at in terms of when you look at the kind of biomolecular structure. And what's different is all of these cancers then once you find the kind of different biomarkers which are identifying these different cancers, they all have different kind of treatment approaches. And that's really why biomarkers are so important. I'm actually going to go on and ask Ken to kind of go on to the next slide and kind of get actually maybe Prof first and then maybe Dr. Toh to kind of comment on when we actually look at a lung cancer patient or someone who's actually suspected to have lung cancer, what's like the journey map? What's the map like in terms of how they progress, in terms of how do we diagnose them? How do we kind of differentiate what kind of therapy they get? And there's this very busy slide, which actually is quite presents a good kind of workflow, and maybe Prof can offer some insights on how it goes through for a patient with suspected lung cancer.
Yeah, I think one of the first things I'd like to emphasize is, like all cancers now, the management is actually multi-modality, multidisciplinary approach. And as you can see here, there are a number of persons involved, each of them playing their own critical or integral roles. Of course, centrally we have the patient. Patient will come with symptoms and he sees a respiratory physician or pulmonologist. And if a diagnosis of cancer is suspected, that sets in motion a chain of events leading to the diagnosis, where pathologists, radiologists, interventional radiologists come into play. If a cancer is resectable, then a surgeon is recruited into the team. And finally, the oncologist who comes in and decides what kind of treatment would best benefit the patient depending on the molecular markers or the various parameters that are derived from analysis of the tumor. I'd like to say that the pathologist actually is involved almost at every step of the process. For example, in a multi-modality approach, even before a biopsy is taken, it is useful to consult the pathologist to alert him that this biopsy is coming, that it's precious, because a lot of these patients who come to us are really not resectable, and therefore a biopsy is sometimes a challenging option. And we have to make sure that that tissue that is obtained is judiciously managed so that the tests that best benefit the patient can be performed without compromising the very little tissue often that is obtained at the time of biopsy. So I'm sure that Dr. Toh might want to quip in now and take it up and add his own value points to the discussion.
Correct. So just going back to Dr. Murali's comment about nasi lemak, I think I would absolutely agree. It's not good enough to tell a colleague, oh, or a patient, you have lung cancer. You have to be very, very specific. You have a non-small cell lung cancer, which is stage 4 with its EGFR sensitizing mutation, or ALK mutation, or ROS mutation, because each is totally and completely different. So when the patient comes to see us, they will present with symptoms first. And then we do a scan and we find out there is a lung tumor or lung mass. This lung mass may or may not have gone around the body and spread to other organs. But the first priority is to obtain some tissue from that mass in order to firstly confirm whether it's cancer or not. Secondly, to confirm whether it's lung cancer. And thirdly, to confirm what type of lung cancer is. So 3 things that are very important. The tissue that we obtain from the patient is obtained via a biopsy, and the biopsy can be done via a CT-guided biopsy externally. So we use a CT scan to place a needle through the patient's skin into the tumor and draw some of the tissue. Or it can be obtained via a bronchoscopy, which means putting a tube down the patient's nose or mouth into the lung and then sampling some of that tissue. So, so this slide that is being shown at the top left, we can see that the needle is going into the lung to obtain some of the tissue, and the tissue at the bottom is only a very small piece of tissue, maybe a couple of mm wide, and it's a precious gold mine of information. So on the far right, that's a tomato being chopped up. Some tumors might look like that, and you may be lucky that we can remove the whole tumor and get lots of information. But most of the time, we only have a small piece of tissue to work with to get all the information we need to guide our treatment for that patient. Guiding the treatment is like a compass, which tells you exactly where to go. If your compass is wrong, your treatment is completely off and may not even work at all.
Right. And I actually want to stop and ask both of you gentlemen, because one of the common most kind of myths that we hear about biopsies is I have quite a few patients who have refused biopsies because they believe that doing a biopsy will actually kind of help push the cancer to all over the body. Any comments, gentlemen, on this?
Well, no, typically that doesn't happen. Although there are some tumors, not lung cancer, for example, where a biopsy is probably contraindicated because tumor may seed along the line of the biopsy tract needle. But for lung cancer, that's not an issue because, again, speed is of the essence. Typically, very soon after the biopsy is taken, a diagnosis is reached and treatment is commenced, depending on what the findings are. So whether the biopsy is detrimental in the way that it may facilitate the tumor spread is not true.
Okay, thank you very much, Professor. Yeah, because it's lovely to kind of hear it from the horse's mouth as well. So I think one of the things that both of them are kind of stressing is the importance in following the diagnostic pathway, and the diagnostic pathway really starts with a biopsy. It's impossible to kind of treat, or really in today's landscape, it might be even unethical for you to even consider treating a lung cancer without kind of getting a biopsy, looking at what the subtypes of the cells are and the biomarkers that are actually involved before you're actually deciding on a treatment pathway and for every patient actually. Dr. To, I have a question for you in the sense that we spoke about this at the last session, but I think it's kind of a good refresher because in the previous slide, the one about the workflow about lung cancer management, we actually divide the patients into non-small cell and small cell lung cancer. Could you just maybe take a few minutes and tell us again, as a refresher, what's the real difference between these two large breakdowns of types of lung cancer?
By and large, the most prevalent cancer we see is non-small cell lung cancer. That accounts for about 80 to 90% of our patients. Small cell lung cancer is a very rare subtype of cancer, which is quite aggressive and tends to metastasize or spread very easily, including into the brain. Small cell lung cancer, non-small cell lung cancer, the good news is we have developed many different types of targeted therapy for, whereas the small cell type, which is more aggressive, unfortunately, we have not been able to develop targeted therapy for this subtype.
Okay, and Prof, really the division between non-small cell lung cancer and small cell lung cancer is only made during the point of histology, right? Basically, only when the biopsy is taken and only then this can be this initial division can be made.
Yes, I think a tissue diagnosis is essential. Sometimes you can use cytology to tell the difference, but basically you need to look at the cells and sometimes even do additional tests to see whether it is small cell or non-small cell. So to summarize, therefore, a biopsy or tissue morphology is essential to make that distinction.
Right, and to kind of carry on, Dr. To, from again coming back to that picture, I see that you've got once you've kind of decided which type of which subtype of lung cancer it is, you need something to identify whether there's a mutation, and this is this where kind of biomarkers come into play?
Yes, so here we really rely on the fancy techniques that people like Professor Padma are able to perform in the laboratory. So we analyze, we go down to the genetic levels. So that means what makes up these cancer cells in terms of their genes, find out which is the switch that has gone wrong to cause the cancer cells to grow. For example, genes like the EGFR gene, the ALK gene, or the ROS1 gene. So when we find the Achilles heel of these cancer cells, now that's when we can match our treatments to this genetic defect in the cells. So without this knowledge, it's like starting up a journey without a map or without Waze. You're completely lost. You don't know where to go. But once we know the genetic defect in these cells, we're able to say, aha, we can use this drug for you.
Okay, that makes absolute sense. Prof, just to kind of check with you, so when say for a lung cancer patient, and then they send you the tissue kind of histology, and you look at it, and you're sending off all these tests to identify which mutation is it. Do you generally run, is it accepted practice in terms of, do you ask for individual tests, or is there like a standardized list or a panel and you test for all these mutations at one go?
Okay. Perhaps before I answer that question, I can just say that sometimes patients may hear the word driver mutation. And I think what Dr. Thor just now spoke about were driver mutations, whether it's EGFR or ALK or ROS or RET. These are basically genetic mutations that occur in the tumor that tend to drive the tumor, force it to grow, become aggressive, to spread, and so on. Therefore, the premise is that if you are able to detect these mutations, there are drugs available that can knock these cells out without damaging normal cells, which brings in the concept of targeted therapy or precision medicine, which is very much in the vogue and is talked about in the lay press as well. So to answer now Dr. Murali's question, we've gone through a phase where we analyze these mutations in a stepwise manner. So typically in the Malaysian population, based on some studies that we've published from our own group, we know that the commonest mutation is the EGFR mutation, which occurs in about 35 to 40% of the population. And therefore, we would test for that first, because that would effectively identify about half of these patients, or slightly less than half of these patients, who might benefit from this sort of targeted therapy. And then we would proceed to test for additional mutations based on frequency of occurrence. So the next one would be ALK if the EGFR is negative, and if the ALK is negative, we test for ROS and so on. So we do this because it is clear now that these mutations don't tend to occur together except very, very rarely. So if you have an EGFR mutation, you're not likely to have an ALK mutation or a KRAS mutation or any of the other mutations. So it is like these mutations are mutually exclusive. And so that was the reason why in the past we adopted this so-called sequential testing. We test for the common ones because that would identify most of the patients and we could start treatment straight away. And then if not, then we would go on to analyze other mutations in order of frequency of occurrence. But we now have other techniques that are available which allow us to identify multiple genes all at once. So, for example, EGFR, ALK, PD-L1, and ROS are sometimes tested together, and the EGFR may take 5 days or more for the result to come out, but the PD-L1 and the ALK result can come out the same day. So to facilitate the work process and to make it more efficient, although it is probably more expensive, we have now embarked on what is known as a parallel testing rather than sequential testing, where test for one, that's negative, test for the other. So now we basically test for 3 or 4 common mutations all at once, hopefully being able to get a positive result earlier and therefore start treatment earlier. And right. If even that fails, then we have to resort to even more exotic testing, which I think we'll be touching on as we move along into this discussion.
Right, and really the reason, Prof. and Dr. Toh, for me asking this is quite a lot of times we get patients who are not so keen to do these further mutation testings, or even you get allegations that, you know, the doctors just throwing all these tests, additional tests, which cost like an enormous amount of money. Why can't they just test one at a time? You know, they'll be cheaper. You know, these are very common questions that our patients kind of present with. So I think Prof has kind of very correctly aligned the thought process that what we are considering is actually the speed of treatment and the speed of initiation of treatment, which really makes a difference. Isn't that, Dr. Toh? In lung cancer, every day is really makes a difference.
Yes, I mean, I can understand both viewpoints. If one, a cost perspective, you know, we shouldn't do tests unnecessarily where there is no treatment, for example, or the treatment is completely beyond affordability, perhaps. The other is we shouldn't delay treatment, initiation of treatment. So if you do multiple tests at the same time, so we are able to get the answer much quicker. But I can see both arguments. I can see both points of view.
And I'll share with you another interesting viewpoint, which is quite very Malaysian indeed, where patients actually find it, they are very unhappy when all the tests turn out to be negative. And then they're like, oh, we spent so much money, but nothing's come out positive out of this. And so that's been another issue of concern as well.
Yes, correct. I mean, it's very disappointing. I think sometimes we set our hopes very high that, you know, there will be this magic bullet that can give us a fantastic response without side effects. But then in the end, you know, patient may only be suitable for chemotherapy or radiotherapy. But, you know, I think as time moves on, you know, right now we're only testing for 4 genes, perhaps routinely. But we know there are many other mutations out there and drugs being developed. So where we are right now will not be the same as where we will be in 5 years' time. So we'll be having a very different conversation.
Yep. And hopefully that conversation does happen. I want to come back a little bit to what Prof was saying earlier. And Prof, you were sharing with us how actually the thought process and the kind of testing process that happens as well. And a lot of people think that, especially now as we get more and more kind of point of care tests, people seem to think they have, or there's this whole conception or preconception that, I slip something into a machine and then I get a result within an hour. So like maybe it might be interesting and enlightening for Prof to kind of share what happens to this whole process when the slide comes out, when a sample comes out to you. How does it, what goes through until you kind of get a result out, Prof? And okay. I think we have a slide on that as well, right?
Yes.
Kenneth?
Okay, so this is what happens, and I've labeled this the journey of a tissue sample. So on the extreme left, at the starting point, the tissue is collected and then it's put into a container with hopefully suitable fixative. And then it's sent to the laboratory, and we go through a series of steps. Tissue processing, there are several steps that are involved there. And then the tissue is stained and the pathologist looks at it. And then makes a diagnosis. And as Dr. Toh has said, we have to make the first decision as to whether this is a small cell cancer or a non-small cell. And small cell cancers are aggressive. And at the moment, there's really no good targeted therapies available. But if it's non-small cell, then a number of tests need to be performed. And specifically, we conserve as much tissue as possible to try and identify driver mutations or mutations that are targetable so that specific therapies can be instituted which may be life-changing in these patients and spare them the toxicity of chemotherapy. So that is basically what we try to achieve. Now this diagram looks very simple, but in the best of hands, even a lot of things can happen. For example, the tissue right up at the start, the tissue that is collected may be insufficient, or it may be difficult to obtain, and only small amounts of tissue may be obtained. It could be improperly fixed because the fixative is bad. It could be left on the shelf for many days before it is transported to the laboratory. At the time of processing, there may be other gremlins that are acting in place to further degrade the quality of the sample. And then once it arrives at the pathologist's desk, depending on where you are working, the diagnosis may be rendered in a couple of hours, or the pathologist may decide that the workload is too much, or there may be other constraints, and the biopsy result may take a week or more to go out. So these are the real life issues that face the fate of a biopsy that is obtained up to the time definitive diagnosis is rendered. In the best of hands, we can probably achieve a same-day turnaround. That means the biopsy is done in the morning, in the evening, the report is ready. But in some centers, it may take up to 2 weeks. So we're talking about worlds of difference in the way that tissue is managed, depending on where the sample is sent to and how it is processed. And from then on, of course, we will take up the molecular testing perhaps in a separate slide, because there too, there are issues, especially time constraints, the testing methodologies, which may impact the final result.
Right. And just before we go to that, so just kind of to stress again to our listeners that even though I think Prof's made this important point that these 4 steps are not kind of something that you can do very quickly, and perhaps it's not like putting in the card into an ATM coming out with a result. And I think what Prof is also kind of could strengthen is the fact that there's multiple QA processes, right, Prof, to
Yeah.
ensure that the sample and the result that you get is actually valid, and that's an important point as well.
Yes. So at every point of the tissue sample journey, various concerns have to be addressed, from the type of biopsy that is taken, and to ensure that it's done under guidance. For example, as Dr. To has mentioned, a CT guided biopsy, and I saw a nice picture of that earlier on. And then to ensure that the fixative is correct, there's quality assurance there too. We've had examples when the tissue was dropped into water, which is completely useless. And then, of course, all the other aspects of the tissue processing and the staining and the rigor of the diagnosis as well is important.
Right. And I think we wanted to also kind of go into the next section where Prof actually would be able to share with us a little bit about how is it that you do the molecular testing. I think we had a slide on that as well, yeah. But I think one of the concerns really for Malaysians is the fact that we're all so used to rushing through everything and everything's expressed. To paraphrase, I think it was a politician earlier who said, hari ini hantar semalam sampai. So our expectations really need to be kind of aligned as well in terms of how quickly we want results, while at the same time needing the kind of accuracy and validity to be maintained. I think, did we have a slide on molecular testing? Oh, okay. So if, yeah, was it this one? No, I think it was the other one. This slide is a good slide. I really want to talk to Dr. Was it this, Prof? This was the one on...
no, this takes it another level. This is a very high-end
okay.
testing, which is next generation sequencing. So I think we really don't have a slide where we deal with the first layer of testing, which is not as complicated as this one, where we use things like PCR or a real-time PCR to look for these mutations that we spoke about. So since we don't have a slide, if I can just mention, the way that EGFR or epidermal growth factor receptor is assayed is typically by real-time PCR, which is highly accurate and highly sensitive. And it's able to detect the presence of a mutant gene in a sample that perhaps only contains about 1% of tumor cells in a background of normal cells. And this is to be expected. For example, when you do a biopsy of a lung tumor, you're not going to get pure tumor. You are going to get some normal cells, you're going to get blood, you're going to get inflammatory cells. And the techniques today that are available are so sensitive that if you have one tumor cell with a mutation in a background of 100 normal cells without the mutation, our techniques can pick it up. So it's a highly sensitive technique. And there are methods out there that actually go down to 1 in 1,000 cells or 1 in 1,000 fragments of DNA. So we have very exquisite testing methodologies that are available thanks to the rapid progression in these technologies, in PCR technologies as well as in genome profiling technologies. So, so EGFR is tested that way. For ALK, it is usually by routine microscopy with immunostains. Again, that result is usually available in 1 day. ROS is tested by a technique called FISH, and that usually takes about 48 hours in the best of centers. And then routinely, we also do a PDL1 to see if a candidate may qualify for immunotherapy in the event that there are no driver mutations. And Dr. Tho can expand on this. Basically, we need to ensure that there is no driver mutation before a patient can be started on immunotherapy. And that too is a little bit of a challenge because at the moment, we only test for about 4 or 5 driver mutations. And although not every tumor will have a driver mutation, it is believed that with the current state of knowledge, at least about 40 to 50%, or even up to 60% in some studies, depending on what technologies you use, you may be able to uncover a driver mutation. So there are about 30-35% of patients whose tumors may not have a driver mutation at all, and that is perhaps an unmet need. And I'm sure that as knowledge progresses, more and more of the driver mutations may become available, and therefore more and more therapies may become available to these patients, some of them it's perhaps very rare mutations. So that is the promise of the molecular technologies that are now available to us. And this field is advancing so fast that brings us to this slide, which is comprehensive genomic profiling. And before I go into that, maybe I can invite either Dr. Murali to challenge us again with some questions, or for Dr. Toh to
Oh, no. I was just going to ask Dr. Toh to kind of elaborate on what Prof was saying about these driver mutations, and how do we actually kind of treat or look at treating the ones when there's actually no driver mutations that show up. I think immunotherapy was one of the things that was mentioned as well.
Yes, correct. So driver mutations, when present, are really the genes that are turned on that predominantly cause the tumor to grow. So that is the main, main thing or main driver in that cell, and no other genes are really playing a major part. That is the major gene that is causing the cancer to grow. So the good thing is, if that is your main problem, if let's say you have a class of 40 students, and it's just one that is always jumping on the table and making noise, you remove that child from the classroom, the whole classroom is settled down. Same thing with the cancer cells. If there's just one gene, we use the drug to target that gene, and and the tumors sorted, the tumors treated. When there isn't just one driver in that classroom, for example, so you have maybe 20 students which are problematic, but they're not all problematic at the same time. That's the situation where we don't have driver genes. But we do have this other treatment called immunotherapy. It's amazing. It's revolutionized the field of lung cancer. We are getting 5-year survivals like we've never gotten before, but it doesn't work in everyone. Unlike driver mutations, the genetic marker for immunotherapy is not very well established. We have PD-L1, which helps us decide, but is by no means as good as the other types of genetic markers for targeted therapy. So PD-L1 is a marker to say that our drug potentially may work. Our immunotherapy drug potentially may work. I'm going to stop there. If you want me to elaborate further, I can.
Okay. I'm actually going to put up this slide on this that we kind of shared a little bit earlier on personalized medicine and how it can improve outcomes, because that just kind of reaffirms our thought or our views now today, and what you're saying today on how much difference can targeted therapy, or the fact that you can now identify a biomarker and then you can put on an appropriate treatment, how much of difference does that make, Dr. Toh?
Okay, Dr. Murali, I turn the question back to you. Treatment A, is that targeted therapy or chemotherapy?
I think it's conventional therapy. I think it's chemotherapy.
Bingo, right, correct. So without any profiling, the default treatment is treatment A, which is chemotherapy. And we know chemotherapy brings only about 30% chance of tumor shrinkage, about 30% chance. But if we profile and then we find that there's a marker, in fact, most of the time we can get treatment B kind of results, about 75% or even more. So I think that this is what this slide is trying to illustrate. Without without profiling or without testing, everybody goes into A. But with profiling, some people go into B, C, D, whatever it is, it's better than A.
I think that's one of the important take-homes for today. We're just going to run into the last couple of minutes of our discussion today, and so it's always good to end on a very, very optimistic note. And you see that little on this slide, you see this little blue thing on comprehensive genomics profiling, and Prof was going to touch on it slightly earlier. Now we're going to switch on to that slide and maybe let Prof give us a rosy picture of what the future holds, if it not already has.
Yeah. So comprehensive genomic profiling is basically looking at your genes in a very deep manner, which means analyzing as many as sometimes thousands and sometimes millions of genes at one go. So when we talk about the fact that today we are looking at 2 or 3 or 4 genes, and we are doing it, sequentially, and now, of course, parallelly. Imagine how this technology basically changes the landscape. It is at the moment fairly expensive technology, but nevertheless, it has the potential of unveiling a large number of potential targets in any kind of cancer, but today we are focusing on lung cancer. As a result of this ability to interrogate the entire genome, the DNA content of the tumor cell, to try and dissect out to see, by analyzing hundreds of thousands, and I said millions of genes, to see where you might find that driver mutation which could potentially benefit the patient because there is available targeted therapy. Now, this technique will work on solid tumors. That means tumors that have been removed as a result of a biopsy, and it's now in a paraffin block. We have techniques to take out the tumor from the paraffin block and analyze it. Or the promise of the future is that these tumors that are present in the body will eventually die, and some of that tumor DNA will get into the blood or even in the urine or into any fluids that may accumulate in the body, like pleural fluids. So the promise of the future is that we should be able to even take your blood, take your pleural fluid or whatever fluids that are readily available without having to biopsy you, and be able to analyze this by subjecting it to comprehensive genomic profiling. So the process is tedious, and at the moment it is still expensive, and it is laborious because it may take about 2 to 3 weeks before a result is available. And the pathologist or the molecular scientist who does the analysis has to be properly trained to analyze the plethora of data that is generated to make sure that some of it is not garbage. We have to sift through that and curate that information to see which of these are relevant and are clinically relevant because there is a targeted therapy that is available before a final medical report is generated. Now, even within this field, you find that there's so much of progress. So we've been doing next generation sequencing for some of our tumors, including lung tumors. We've had actually studies that have been initiated by pharma called the Nexus study, and we're going to commence on a Nexus 2 study soon. This is very exciting an area. So 2 to 3 weeks is the standard. But there are technologies in place right now where we can do next generation sequencing and a result is available in 1 day. So that's amazing. And I don't want to plug it, but we are going to acquire such a machine within the next couple of months.
Okay, so and perhaps now the kind of now that you've told us about this wonderful thing, why are we even bothering to do biomarker testing? Dr. To, why don't we just, everybody that comes in, we send the tissue down for genomic profiling and upfront straight away? Can this work? Why don't we do it?
Okay, so a bit of an analogy. So if you do limited biomarkers, 4 or 5 gene. So Dr. Murali, I'm very short-sighted. So are you short-sighted?
Actually, I am as well. As you can see, my glasses are so thick.
So for me, it's like taking off my glasses and trying to look at a person or a view or a piece of scenery. Doing comprehensive genomic profiling is like putting on my glasses and looking at the same picture. You can see such detail in the genetic makeup of the tumor. But the problem is sometimes you put on the glasses, it may not be a pretty picture. It may be a very ugly picture, actually. So you may not like what you see. The same with tumors. Tumors are genetic profiling, no matter whether it's 4 genes, 10 genes, 1,000 genes, is only useful if you can find a target. The problem is you may find the gene that's involved, but you don't have a drug against that gene. And that's the problem. Drug development has not caught up with genetics. So in a lot of cases, when you do all this amazing profiling, we find the gene, but we don't have a drug against it because the science or our technology hasn't managed to develop a drug. It most probably will develop a drug against it in the future, but right now we don't have a tool. So sometimes you could argue maybe it's better to limit the resources just to test for the genes where you have something against it, rather than doing a comprehensive look at the cancer. But even if you find something, you don't have a bullet against it. And it's more costly at the moment. The cost will come down than doing a limited profile. So for speed and for financial viability, normally we will do a limited profile. But more and more, as Professor Padma says, and I completely agree, we need to be looking at genomic profiling. And I think that is the way of the future.
And Prof, maybe this is just a curious question, because now more and more you start seeing a lot of people actually coming up with solutions where they can, there's companies offering you upfront, instead of buying instead of buying a car, invest in your genomic profiling. So how about normal people who have no cancer whatsoever, no suspicion of a growth? Are these tests like genomic profiling available for them in the market today?
Yeah, there are. There are many companies that sell wellness profiles, cancer risks, and these have the ability to test various things. I mean, the commonest, of course, is to look for BRCA genes to see whether you are at risk for breast cancer or whether you are at risk for ovarian cancer. So similarly, there are many inherited genes or what we call germline mutations, which are passed down from parent to child. And there's a lot of interest now, part of it may be a media hype, part of it is because of the Angelina Jolie effect and all of that. People are invested also in wanting to know whether they have enzyme defects that make them sensitive to various kinds of drugs. And the techniques are in place actually to see whether, like gout, whether you are sensitive to allopurinol and whether you should not be prescribed because that can precipitate an anaphylactic shock. So all of those things are coming together. There's a convergence of these technologies, not just to look at cancers, but also to see whether they can contribute to your wellness. There are certain things like tendencies to diabetes, tendency to Alzheimer's disease, and so on. So it's a huge market out there. And there are many companies that are invested in this. And you can actually, those of you who are in the know will know that there's 23andMe, for example, where you can spit into a tube and send it away to the US, and they will do a genomic profiling, and it comes back to you saying that, you are at risk for this and that. Or, there are tests that can actually trace your genealogy. So it's a huge market, so not just
Okay.
in disease, but also in health.
Okay. And I'm just curious. I'm going to ask one to Dr. To. Dr. To, so let's say I upfront I already tested for this without I have no inkling of disease. I've tested for this, invested in this, and done a genomic profile. Subsequently, later, let's say I do develop a lung tumor of sorts. Do we then need to repeat the test, or using this existing genomic profile that I've done, I can already start treatment?
Okay, so I think this technology is amazing. It's fantastic. It's coming, and it has a huge potential to help mankind or human beings in terms of how we prevent diseases and so forth. But we are not there yet. So, for example, if you do detect a BRCA gene that you did, out of your own volition, you're going to be very hard pressed to get proper insurance coverage. And it has implications for your children as well, because if you carry an inheritable gene, the insurance company will want to know whether your kids are potentially have that gene before they could be insured, for example. So back to your question, yes, if you have a particular genetic mutation which is known to cause cancer, most likely that gene will be carried down to your cancer cells. So there's a difference between germline and somatic. Germline being genes that are present in every cell in your body, and somatic means that particular genetic profile of the cancer. But for cancer to develop, they may have acquired different other mutations on top of the mutation that you have. So whenever a person develops a cancer or tumor, we have to reprofile. So we have to check that cancer cell for additional mutations that may have occurred along the way.
Okay. So thanks. So that's really helpful to know. And I don't want to actually put that out and kind of influence your answer, but thank you for that very interesting illumination about the issues pertaining to genomic profiling. And this is the difference. Again, I think the legal framework in Malaysia hasn't quite caught up with countries like the US, where there's already
genetic discrimination law.
Genetic discrimination law, which I think really we should work at in the nearest future. So there's another kind of innovation, perhaps, that I think we are now looking at in terms of cancer biopsies. And we talked, I think, so far about solid tumor biopsies or tissue biopsies. And there's something called liquid biopsy now. I think we have something about it. Prof was alluding to that earlier, and maybe Prof can give us a little bit of insight on what this thing is.
Okay. So I mentioned earlier, liquid biopsy basically is different from tissue biopsy because we are looking for mutations, or we are looking for driver mutations or sensitizing mutations in liquid from the body. The commonest liquid, of course, is blood, but there are tests that can actually have passed the robustness test, and we can look for these mutations in urine, in pleural fluid. Saliva has been mentioned, but saliva is actually a very bad sample. So I don't think there are any studies that have actually validated saliva as a liquid biopsy. But certainly CSF, certainly pleural fluid, acidic fluid, blood. Blood is the commonest and the most readily accessible. It's a venipuncture. And the advantages are huge. But one of the things that the cautionary statement I have to make is that while it is in a way non-invasive, it is not 100%. So if you have a patient with a lung cancer and the patient is amenable to a biopsy, I would always go for that first. The tissue biopsy is the gold standard. Because there are several advantages of doing the tissue biopsy right off at the start. It will help us decide whether it is cancer or not, whether it is primary to the lung or not, or whether it's coming from somewhere else, whether it is small cell or non-small cell. So all of these This information at the present time cannot be got by looking at the liquid biopsy. Also, if you wanted to do things like immunotherapy testing, at the moment, PD-L1 and some other tests like MSI have to be performed on the tissue. So there are many, many advantages. But liquid biopsy is not without its place in patients who are too sick to have a biopsy, or if the tumor is an area which is dangerous to biopsy, for example, in lung tumor very close to a large vessel or to the heart, or if the patient presents with bone-only disease, and which we try and avoid. So things in those situations, perhaps a liquid biopsy may be useful, with the caveat that if the liquid biopsy is negative for mutation, to best benefit the patient, we should attempt a tissue biopsy to ensure that it's truly a negative result. So Dr. Tho might want to add to that, and then if necessary, we can further discuss and expand on this.
Sorry, Dr. Tho.
Yeah, no, I think nothing much to add. I think very well put by Prof. Padma. It's a bit like science fiction, isn't it? You know, you just take a blood test and you can tell everything about what you need to know. But actually, we're not quite there yet. As Prof. Padma points out, there are limitations. But certainly, I mean, I think I'm very optimistic. I think things are coming. Good things are coming.
Right. And I think the technology has just changed so much in leaps and bounds. I remember when I was when I was young, we used to, I think, watch Star Trek, and they used to have a little pinprick gun, and then on which the medical guy, whoever it was, McCoy or whatever, and used to run all the diagnostics right off that single pinprick and give you a printout on his screen. So we're not all that far away from that today. So this is coming. I'm really sorry to be wet blanket and kind of point out that time really is overrun a little bit, actually quite a bit. And then so I just want to ask whether we have any questions at this point in time. I know Kenneth had one. Kenneth, you were saying? I think we can take one question. That's about it.
I was just looking at the chat from the audience. There is not one question yet, but I think since the time is coming to the close, so that's just building on Dr. Murali's saying, we might want to close the session with more positive. So I'm asking this on behalf of everyone. So as Dr. Tho has mentioned to us, lung cancer has actually contributed to a large amount of mortality, means death. So with the advancement of now precision medicine as well as genomic profiling, what should we expect in terms of impacts on the survivorship for lung cancer patients in particular? Yeah, maybe Dr. Tho and Prof can give us some insight on this.
The statistics, the worldwide statistics are based on data which is a couple of years old. That's always the case. You know, we accumulate the data, we mull through it, we analyze it, and then we publish it. So I suspect, you know, in the next 5 to 10 years, we'll be seeing a very different shift in terms of the mortality statistics for lung cancer. And as we push for earlier and earlier screening, as well as better and better treatment, I think we will see a big change. However, it's left to people like yourself, NCSM, and us, Lung Cancer Network, to really push the message out there and to really get stakeholders, patients, relatives, wives, nagging husbands to get checked out and treated earlier and earlier.
Prof, I wanted to invite you to perhaps leave us with some important points to go to as well.
Right. To me, I think lung cancer is a bad disease to have. I mean, cases are being diagnosed almost as fast as they are dying. So we seem to be running on the spot. And the grim statistic is that somewhere, somebody is dying of lung cancer every 30 seconds. So it is a bad disease to have. As a pathologist, I look to the future as technologies becoming available. Liquid biopsy will probably become more and more important. as comprehensive genomic profiling becomes more efficient and cheaper, we should be able to offer this to more and more patients, be able to work with pharma to discover mutations which are driving the tumor, and perhaps together participate in the testing of new drugs as they become available. And I want to also leave with the thought that for me, liquid biopsy is not just for diagnosis, but it's also for early detection of recurrence, for example, because the technologies are in place that if you have tumor and you treat and the tumor goes away, it is eventually going to come back. In most of these cases, at least for lung cancer, we know that that's true because resistance develops. So liquid biopsy has a potential because you can continuously monitor these patients. It's a simple blood draw. It has the potential of detecting early recurrences so that we can institute therapies earlier. And therefore, it becomes an important monitoring tool, just like we are using things like PSA and other biomarkers to detect early recurrence or early detection. So that to me is the way forward. And I look forward to the day again where lung cancer will be something like, managing lung cancer will be like managing bronchial asthma. It's a chronic disease that never goes away, but we continue treating it because newer and newer drugs are becoming available and we can keep the disease at bay.
Right. Dr. To, perhaps if you had something to kind of add or to go home with as people finish their teh tarik and go to their dinner already.
Well, that's a long teh tarik, 1 hour teh tarik.
Yeah.
Okay. Genes are amazing, right? They control the color of my hair, my height, my ability to calculate mathematics, but they also control tumors. So it's so important to understand your enemy, and genetic profiling and testing of biomarkers is what we need in order to understand our enemy and overcome it.
Okay, so there you go. Gentlemen, thank you very much, I think, for taking time off your busy schedules to actually come and do this session today, and hope this session has been insightful for everyone who's been listening. The videos continue to be available on both on our Facebook pages, on LCNM and NCSM Facebook pages. Please share, please kind of spread the news so that people can continue watching it if they were unable to join us for this session. Thank you very much all, and a very good evening. Happy Selamat Hari Malaysia.
Thank you very much,
Prof. Thank you, Doctor.
Yeah, thanks to Roche for helping organize this very interesting event. I learned a lot myself.
Thank you, Doctor.